patients that it may be difficult to dry out the macula completely, either because you just can't, that blood-brain barrier is very compromised, or there may be other factors like epiretinal membrane, which may limit the amount may limit the drying of the macula. And it's just interesting, particularly with the recent data published by Roche with faricimab, where they had a personal treatment interval. It's just interesting that they didn't necessarily aim for a dry macula, and in fact, so long as the macula was, below 325, that was tolerated, and those patients still had good outcomes. So how do you kind of reconcile that? I agree with you. You've shown some really good data that to dry the macula is the best thing, and to give the best visual outcomes. But actually, on an individual level, there are some patients where you might be able to tolerate a bit of fluid. What are your thoughts, Ahmed?
I totally agree with you, Dr. Mohammed. What I believe in is the exact pathogenesis of DME is not yet well understood. We're still missing some element there. And I totally agree with you. We have to try to dry as much as we can. But if we have some like degenerative cyst or chronic cyst, the small cyst is not increasing in size or number, so definitely you can watch those kind of, especially if the visual acuity is stable. But sometimes as you mentioned that in some cases, which is not too much, you might that. But also again, and that's why they opened the discussion for, when I mean that there is not still well understood, because what we are doing now is we are targeting only the overexpressed VEGF or inflammatory mediator, which is in the extracellular space. But the new drug coming, as you mentioned, they are targeting different pathway. They are trying to work now on the cellular level. And I believe when we have more drug with more different mechanism of action and different level of action, and like, as I mentioned, on the cellular level, like anti-angiotensin-2, there are also a lot of drug in the pipeline target another pathway. So I believe at that time we can reach the dryness. But what in our hand, the message I want to deliver here, as you mentioned, and I totally agree with you, treat as much as you can. And if you find that a small cystic or it's still there, not visual acuity is affected or stable, but in the same time, you should put eye on those patients, closely follow up. If the increase in size of the cyst or the number, it means an early sign of activity. So I think it's a time to retreat again or initiate the treatment again.
Thank you, Ahmed. Thank you. We can continue after we finish with Dr. Raif. Okay, Dr. Danish, I think we will have Dr. Raif, but all the day with us. We can have a lot of discussion at the end. Okay, can we have Dr. Raif if you are ready, please? Dr. Raif, you are mute, maybe.
Dr. Raif is muted. Yes.
Dr. Raif, yeah, please.
Yeah. Okay. So to be honest, it's challenging to provide a challenging case of DME because DME is either responsive or unresponsive, and in between, which is the mediocre or suboptimal response. So this is a case of a challenging case of DME. I will try to share with you, and we will see together how to manage. So this is a female patient, 62-year-old. She's diabetic since 12 years, hypertensive since 7 years, suboptimal control of her diabetes, HbA1c 9.3, presented in 2019 in May, complaining of diminution of vision in both eyes, more in the right eye. So the right eye is phakic with normal eye pressure. Best corrected visual acuity was 0.3 with some hyperopic astigmatism. Fluorescein angiography showed some PDR with diffuse leakage maculopathy. So this is her OCT at presentation. You can see here there is significant intraretinal fluid collection on multiple layers of the retina with some hyperreflective spots. Disorganization of the inner retinal layers, as well as subretinal fluid collection. There is also, you can notice, some thickening in the LM at the surface of the macula. So to begin with, we started with systemic control of blood sugar and blood pressure. She received the PRP session. She started PRP session immediately and started immediately intravitreal injection of ranibizumab as well. So after 3 months, 3 months of injections of ranibizumab, her vision improved significantly to 0.3, and HbA1c was improved gradually. Of course, abrupt reduction of or tight control of blood sugar might lead to deterioration of diabetic macular edema. So it was gradually controlled to 7.3 along 3 months, 7.6. Then we continued intravitreal injection of ranibizumab, and in September 2019, vision was stable at 0.9, and then she missed one injection, and then she came back in October with a 0.4 and reaccumulation of intraretinal fluid collection, as you can see, and she started to complain again. That's what's made her come back. So we obviously resumed intravitreal injection of ranibizumab with visual regain into 0.5. Again, another injection was received. However, we can notice that there is reduction in vision despite some improvement in visual acuity. So you can see that the OCT is a little bit better. Still, there is some accumulation of macular edema, but it's improving. However, from the patient's side, from the patient's perspective, she was 0.3 and complaining of diminution of vision. So repeat injection resulted in further improvement in the OCT in mismatch with the reduction of visual acuity, and it persisted to be 0.3. So what's next? We started to give another weapon in our hands, which is intravitreal steroids. She received intravitreal Ozodex injection in January 2020, but then she turned out to be a steroid responder with the IOP raising above 35. However, we can see that there was much improvement in the diabetic macular edema, the almost subtotal resolution of the intraretinal fluid collections and subretinal fluid collection. Still, there is some hyperreflective spots. However, patient was happy. Her vision improved to 0.5, up from 0.3. Continued improvement, and she was 0.5 again after 2 months of injection. However, along came Corona. So we had to, she came back like 6 months after the injection of Ozodex with a significant decrease in vision, despite the fact that the macular edema did not much improve, did not much deteriorate. You can see here, there's not much of a significant thickening and accumulation of intraretinal fluid as compared to the initial presentation. However, visual acuity significantly decreased to 0.2. So we resumed again ranibizumab injection, and she received 3 injections with remarkable improvement to 0.5. Okay, that's everybody's happy. But what's next? Obviously, we had to continue injection. However, despite continuous injection of ranibizumab, the fluids started to accumulate and become resistant, despite the perseverance in receiving the injection. So she was receiving the injection, and the fluid did not much improve, despite that was after 1 month of injection, it was 0.3. And you can see the cystoid fluid and subretinal fluid collection. So what's next? We decided to shift to another molecule. Maybe we can find the difference. So she received aflibercept with a significant improvement from 0.3 to 0.6. However, you can see the cystoid spaces did not much improve. However, patient was happy and everybody was happy. So she came back later on for the second injection of aflibercept, and vision decreased to 0.4. And you can see here The fluid is becoming more resistant than before, and very much less response to the aflibercept. So what's next? We continued again, intravitreal aflibercept, and vision was stable at 0.4. So we continued again, but however, it was completely unresponsive to aflibercept after the third or fourth injection. So patient was complaining, and a huge cystoid fluid collection is accumulating in the fovea, and the vision decreased to 0.2. So at this moment in time, what's next? So it was a hello?
Yeah, Dr. Raif, can you hear us?
Yes, I can hear you.
Okay, you finish?
Okay, can continue again?
No,
you share my presentation?
Okay, you finished the first case, right? Hello, Dr. Raif, can you hear me? Dr. Raif? Dr. Ahmad?
I'm not sure if the connection is okay.
Yes.
Can you hear me? Everyone is hear me? I think
I can hear you. I can hear you, Dr. Ahmad. Yes.
Okay, so I think we are having some problem with connection.
Carry on. She received in.
Because Dr. Raif, you already stopped share. Now we are not seeing the presentation.
Okay, now it's stable, the connection?
Yes, okay.
Yeah, we can see now the slide, yes.
Okay, can you go ahead to finish,
Okay,
because
sorry.
already we are done.
Okay, so I resumed again intravitreal ranibizumab after the stopping the response to aflibercept, and then vision improved at 0.4 with mediocre response, let's say, to the resolution of the repeat injection of ranibizumab. She's stable at 0.4. Repeat injection again, stable at 0.4. And in fact, you can see that the fluid is almost totally disappearing. However, vision never came back to 0.6 that she was there.
Can you show us, because we are
And
already only
still pending.
Okay.
Yeah, that's it. So thank you. This is a case of very response to anti-VEGFs, and just wanted to share it with you to raise the issue of tachyphylaxis and the suboptimal responses. And you know, this is from real life, and yeah, we all face these cases. You know how it goes.
Okay, thank you very much, Dr. Raif, for this an excellent case presentation that we are, I think most of us, we are facing similar to this most of the time. I don't know, we will see now if there is any comment. I will start with Dr. Danish. If you have any comment about this case.
Actually, I wanted to talk about the fluid which Dr. Ahmed was talking about. See,
okay.
We're talking about trying to remove as much fluid as possible. So question one, you have a patient, you're giving the injections, and the patient's now 6'6", 20/20 and N6, but there are still some cysts. Would you continue to give the injections?
Dr. Ahmed.
Yeah, I think 6'6" vision, you know, what is the distribution of the cyst? What is the cyst exactly? As I mentioned, if it is in the superficial layer and it's parafoveal and not affecting the vision, definitely I can watch him, because the patient is 6'6". We cannot inject, because also if you have any complication happen, for God's sake, from the injection, it will be a case. So and that's, if you reach 6'6" vision with a small cystic change, that means that this cyst is not affecting the vision, and it might go away if you keep eyes on those patients. So don't rush, especially if this vision was worse than that and improved. Yes, we can stop and watch. Another important point also I want to highlight here is the control of the blood sugar. It's very, very important. I have some patients came to me with the small cystic changes at 20/25 vision, and I offer him injection, and the patient refused because he was afraid of injection. But I asked him, okay, the hemoglobin A1C was 9, and after 3 months he came back to 6. He's very tight control, and interestingly, the cyst disappeared and the vision came back to 2020. So I believe control of blood sugar is a very, very important. And that's take me also to the case of Dr. Raif. If I can comment on that.
Can you Ahmed just stop on the
okay, sorry, I'm
okay.
just asking.
Yeah, and if you don't, we want just to have to
because there's a
benefit from the time. So if you can get a very sharp and direct to the point, if you don't mind. Okay.
Mohammed, I just wanted a quick question for Raif.
Yeah.
Why do you think the eye became receptive to ranibizumab after initially it was resistant and you needed to switch to Eylea? You know, why did you get that ranibizumab Eylea to ranibizumab switch? Is there anything to the anything to do with the fact that they use steroid?
No, it's not related to steroids, because after following the steroids, she received ranibizumab again. And following reception of ranibizumab, she became unresponsive. And only she became responsive to aflibercept. But then again, it was resistant to aflibercept. And to be honest, I improvised. I had not much of a tool to go with. So I thought of tachyphylaxis again if it's initially responsive to aflibercept, and then maybe now it's not responsive, so it might go back responsive to ranibizumab. How do I know if it wouldn't? So that was the only option to do. The other thing I could have gone through maybe was sub threshold or micropulse laser, but at that moment in time, we didn't have the machine, so that's what I could do. I couldn't think of vitrectomy because, you know, the condensation of the ILM was much less than justification of such a surgery.
Very peculiar case. Very peculiar case. I'm not sure the mechanism. I can't think of. Tachyphylaxis is a good point, but I just don't believe in it as a reality. Sorry, I think Dinesh was going to make a point. Sorry.
Yes.
I was going to ask that supposing I have tried aflibercept. I mean, supposing I've started with ranibizumab, got a resistance, gone to aflibercept. If I get resistance to treatment, I would actually next think in terms of going back to Ozodex.
Yeah.
Because, you know, Ozodex works. I mean, I don't want to give Ozodex more than twice a year. I would still prefer to stay on a 6-monthly dosing with Ozodex. And in the interim period, it's good. It's a good way to use an anti-VEGF agent. You could use ranibizumab or aflibercept. So if I felt aflibercept was no longer working, my next drug of choice would be Ozodex.
I think Dr. Danish, Dr. Raed, he mentioned in his case that he used already steroid, but he have a high intraocular pressure. Maybe can you tell us, maybe this is the reason? Yeah, it was 35. He was getting a high intraocular, but I think this is why I didn't ask him why you didn't go to the steroid. But maybe Dr. Raed, if you can just clarify this point.
It's true. That was my next plan. If it's not responsive to ranibizumab, I would have injected the steroids despite the fact that's being steroid responsive, and then go for a trabeculectomy or control with medical treatment. But for the time being, since she's responsive with ranibizumab, so I'll keep her on ranibizumab. But that's the answer to you, Dr. Dinesh, that I did not start with Ozodex immediately because she had an IOP rise of more than 35. And I had to watch it carefully. And she also spent like 6 months without observation during the Corona time. I didn't want to repeat the story.
Okay, Dr. Raif, I have a question about.
1 second, Doctor.
Yeah.
Would you try off-label brolucizumab in this situation, because you really don't have too many choices?
It makes very good sense. We need a stronger molecule that's depleting all the intraretinal fluid for her. And maybe it's the answer to this case, to the dilemma of this case. So we're waiting for such a molecule to show up in the market. Absolutely.
I think Dr. Danshi asked you, Dr. Raif, off-label. He was. Are you?
I can. Okay.
He don't want to answer in this way.
I don't think answer
after. Off life. Okay, Dr. Raif, do you think maybe if you use, I know there is an high intraocular pressure. Did you control this with one molecule, anti-glaucoma, or 2 or 3? How do you control it?
I gave her initially Ganfort, which is a double molecule, but then it remained 23, 24, so I added Simbrenza. So I jumped from 2 to 4, and it was brought down under control. I was satisfied after the second month, but then she disappeared. I don't know how she was controlled.
No, but Dr. Raif, this is, you know, a temporary raise because of, I mean, to steroid. If it is temporary, I mean, only, and you can't control with one, I mean, anti-glaucoma, 2 drugs, or even 3, then why you didn't go even for, I don't know, I'm just asking. Did you think of, for example, not only Ozodex to go for Illuvian? Because it is a very
steroid responders, they might surprise you. And initially, once you have a rise in IOP, you might go into a recalcitrant glaucoma, which is not respond. Initially, it might respond to anti-glaucoma, but then with time and repeat injection of steroids, you might have resistant glaucoma. I faced issues like this with people for whom I insisted to re-inject with Ozodex. So initially, you might have a good response with glaucoma, anti-glaucoma medication, but then eventually you might end up with a trabeculectomy.
Yeah, this is my question, Dr. Raif. That's why I ask you, because if the glaucoma, after using anti-glaucoma, did you continue this treatment? So she continue on only or for a certain period? Because if it's a certain period, I don't think it will be need. I mean, you can use another steroid, even if Illuvian. And I mean, if you now do the balance between improvement of the vision and tackling the diabetic macular edema or raise the intraocular pressure, I know it is a dilemma, but sometimes maybe you need to give something like this. This is my opinion. And then you can treat the glaucoma, even if you go for a surgical intervention later on.
Absolutely.
Yeah,
it's true.
I don't know.
Mohammed, can I just say something? So I think the issue about the Illuvian, I mean, I do share Raif's reticence because of that pressure spike. However, if the intraocular pressure can be managed and controlled with drops, and this patient is getting insufficient response to anti-VEGF, then I do feel comfortable about using, you know, a longer-acting steroid like Illuvian. And then I would just warn the patient that there may be a risk that you might need glaucoma surgery. But at the end of the day, you know, there's no point trying to avoid there's no point trying to avoid glaucoma surgery if then the vision is lost because we've not had good control of the diabetic maculopathy. But when you have that pressure spike, I think you've just got to be cautious and consent the patient carefully and make sure that that raised intraocular pressure is manageable. And if it is, then I think Illuvian is an appropriate course of action until we have another molecule that's more powerfully drying.
Ahmed, yes, I think you are.
I thank you, Raif. It's a very nice case. I will have another point, because as you mentioned, your case was BDR with diabetic macular edema, and as I mentioned, as I understand from the case, that you start with PRP together with the anti-VEGF. So my question, what I usually do in those cases, if I have a BDR with DME, usually I start with anti-VEGF first, the protocol S, and then after drying the macula, then I defer the PRP, because my understanding or my hypothesis that if you do a full PRP at the beginning, there is 2 things. First thing, that you will increase the edema, and in the future, any overexpression of the VEGF, the only place that the VEGF will affect is the macula, because there is no other retina. All the retina is burned with laser. So you will have such kind of resistant cases and sometimes respond or not, because all the changes will be on the macular edema. So do you think that doing PRP as a deferred and starting with protocol S or anti-VEGF first until you dry the macula, and then you do the deferred later, rather than starting with the PRP together with the anti-VEGF? So what do you think about that?
The idea, yes, is valid to prevent progression of DME with the edema coming from the inflammatory response to the PRP. However, when you start the PRP, you don't do the full PRP in one session. You just start the initial session with the inferior third, let's say, or inferior quarter of the retina, and at the same time you start injecting, so that you can hit 2 birds in one stone. You don't defer the laser because it starts after a while to prevent vitreous hemorrhage. At the same time, you do the injection meanwhile. So you don't induce much of inflammation. So you don't have to defer like your idea is to defer for 6 months, right? Or
yes, sometimes
Yes.
for I mean to start with anti-VEGF another, because the anti-VEGF the mechanism, I mean the action or the effect of anti-VEGF is much more faster than the laser, because you know we injected the anti-VEGF 3 days before the surgery to decrease fibrovascular to the vascular elements. So I think you will be away or be safe in terms of vitreous hemorrhage, because the anti-VEGF will definitely not only treating the DME, but it will also regress or decrease the severity scale in terms of regression of the new vessels at the beginning. And then you will try, because we know one of the side effects of PRP is inducing macular edema, and this patient already has macular edema. So another point, because sometimes also we see that not related to your case, in some cases, because we forgot a little about fluorescein angiography, sometimes we have a dry macula and everything looks fine, but the vision is not improving. So I think on those patients, it's better to do a FFA to look for macular ischemia, because sometimes if the macular ischemia is there, so there is no valid point of treating this patient, because the visual acuity improve and you have dry macula. And it was in your patient sometime at certain stage, the vision does not improve a lot despite the improvement of the macular edema. So I think this is just a message for all of us, that to put our mind to look for macular ischemia if the vision does not improve, despite the fact the improvement of the macular edema. But anyway, thank you. It was a nice case.
Ahmed, sorry to disagree with you slightly.
No, it's okay. No,
So,
go ahead, boss.
For me, you know, when you have
which point disagree, the ischemia or the PRP?
I know the no,
he will tell you. He'll tell you.
The timing of the PRP.
Oh yeah, okay, yes, sure.
For me, the issue I have is if you have a reliable patient who understands, then it's okay. Then start off with the anti-VEGF. However, I never know whether I might lose that patient, and so therefore for me, although I want to combine, if I have a patient with PDR and DME, I definitely want to do a combined approach to get the best visual outcome. But I tend to give the laser first, inject them a couple of hours later, continue to inject them, and then supplement the PRP. But if that patient were to default from my clinic, then although they will come to some harm, it will be some recurrence of macular edema, but hopefully the laser will protect them from some of the significant sight-threatening complications. My worry is if their proliferative disease is just managed with anti-VEGF, that there is a risk that if they default from clinic, that they can develop traction rail detachment or other complications that can lead to significant loss of vision. And because you haven't seen them in a timely way, or the patient represents in a delayed fashion, that even with your best will in the world to rescue the vision, the patient it's damaged.
Yeah,
and it's just.
I totally agree with you.
I like to get the PRP early.
So that's
we have
I think
Dr.
I have
Danish,
to,
please?
Just I want to have a comment, Dr. Muhammad. Sorry for Dr.
Very fast. Okay.
Sorry, very fast. First of all, you have 2 points. It's very important. You mentioned if you really start to do anti-VEGF, you have to really educate your patient about this, that the value or the importance of attending the clinic. And also another very important point you mentioned about the tractional detachment. Definitely, I will never give anti-VEGF if there is a fibrovascular membrane at any stage. Before we use a small membrane, you can inject, but some cases, if the membrane is small, you interestingly or surprisingly, you find this membrane contract and do the localized detachment at this area. So thank you for highlighting these 2 points. So first of all, you have to make sure the patient is compliant. Second point, don't inject if any element of fibrovascular membrane to avoid crunch phenomena. I totally agree.
Okay, can we have the last comment from Dr. Danish, please? Yes.
Yeah, so basically what Dr. Fahd was highlighting, we know that if you have a patient on monotherapy with anti-VEGF who loses follow-up, 50% of these patients can come back with very severe traction detachments or vitreous hemorrhage, and you can lose these eyes. The important thing is that when you start, you're not giving an anti-VEGF again and again. If you give an anti-VEGF and follow it up the way I would do, 2 weeks later, between 10 to 14 days later, I start the PRP after giving the anti-VEGF. Complete the PRP in 3 to 4 sessions minimum, so that there's no chance of increasing of the macular edema. Macular edema occurs when you do too much of laser in one go, or use too high intensity burns in one go, or the patient has nephropathy. These are 3 important conditions where macular edema gets very badly exacerbated. So this is the important thing. And if you do that, you will not get an increase in macular edema. You're able to complete the PRP. And this PRP is not till the equator. This PRP must go up to the aura. The biggest problem is we go by the ETDRS rules, which were made because at that time the lenses could not go beyond the equator. Now our lenses can go all the way to the aura, and most of the ischemia is nearer to the aura. So this is the area that must be covered by the laser. And in fact, that can bring down the incidence of macular edema. If you see the protocol S, patients of diabetic macular edema, when treated by laser with PRP with anti-VEGF, the number of anti-VEGF injections went down to half. So that's the important thing.
Thank you very much. I think we have many questions about the case that presented by Dr. Raif. It is an excellent case. And if we continue, we can have the whole session about it. So let us move with the other cases, then maybe we can discuss the other point from the other cases presentation. Can we have Dr. Danish now, your case, please?
Can you see the presentation?
Yes, we can see, please, yes.
Thank you, Dr. Amri, for inviting me for this case. Last time I wasn't ready. This time I thought, let me have one case to present in the meeting. This is my disclaimer. And now, this is a patient who was a 58-year-old gentleman, had history of diabetes for more than 10 years, history of vitreoretinal surgery for a vitreous hemorrhage with traction detachment in the left eye with poor vision postoperatively. The right eye had proliferative diabetic retinopathy with center involving macular edema. Now, basically, this case is the story of his treatment from 2014 to 2021 and the lessons that we've learned from that. This is how he presented his. This is the fluorescein angiography at presentation in 2014. He was lasered, and despite the laser, you can see there was persistent neovascularization in 2015. Despite this is an year later. Now, if you see this patient, he received initially intravitreal bevacizumab, just one injection in 2014, and then he received another injection in 2015. And after that, now you can see throughout, despite that, in 2015, despite and 16, he's got Lucentis, and despite the Lucentis, we found that there's hardly any improvement occurring, and finally he was given Ozodex. When he was given Ozodex, there is a response coming. You can see the response started coming to the treatment, and during this period, he had a visual acuity of 6.9 and N8. That's 20 by 32 and N8. Now, subsequently, what we got is a post-Ozodex rebound. This rebound was then managed with Lucentis again. And you can see over here, some response was there to Lucentis, but not adequate. You can see these large cysts persisting all the way for the next 6 months. Then you can see over here, we've given another Ozodex on 8/6/2017 because the Lucentis was not working well. And despite the Ozodex, this time we did not get much of an improvement in the macular edema. When we didn't get this response, the patient was given an intravitreal injection of Eylea, and it seemed to work for him. And you can see following the Eylea, the edema went down. And Eylea, incidentally, at that time was very expensive in our country, so he couldn't afford Eylea on a regular basis. So this is where we were. This is probably the best he ever got with treatment. In the meantime, you can understand that since he was also getting anti-VEGF agents, the persistent PDR became lesser and lesser, and complete resolution of the PDR occurred by 2017. This is also to highlight that just because you've done laser doesn't mean the PDR will go away. You still need to check out whether your laser is adequate, and a fluorescein angiography is important for that. Now, in the meantime, the macular edema, you can see, comes back. He's on eccentrics, still not responding. And now we've given him a third Ozodex. This time he responds a little better. You can see in the next 2 months, the edema again came down, but the same problem. He gets a rebound after Ozodex. And how do we manage the Ozodex rebound? We again shift him back to eccentrics to tackle this, but this time this intravitreal Lucentis, incidentally, Lucentis in our country is called eccentrics. So that is ineffective. You can see over here, this is to show there was some response initially, and then this response, while the eccentrics is being given, the patient starts deteriorating. You can see over here, despite monthly eccentrics, there's a worsening going on, does not respond. Finally, the patient got sick of it for some time. So we said, all right, let's see what happens if we don't give you any injection. And there was a slight worsening, and that stayed at. And then since it was worsening, we decided to give him Eylea. And this time, despite the Eylea, he worsened. Now, this is post Eylea. The patient actually worsened rather than improved. He was given another ranibizumab, no response, non-responding. What do we do? The question here, I have a patient not responding well to Ozodex, not responding well to, can't afford at that particular time Eylea. What do I do in this? Well, let me answer this myself. We didn't do anything. We left him alone. And guess what happened? His improvement occurred to a level that had not happened in the past 7 years. And the vision improved both subjectively and objectively. Near vision was N6, distant vision was 6/9. So what happened? How did this improvement occur? This improvement occurred because he controlled his blood sugar. Amazingly, during this was the COVID phase. If you look at this period, this was the COVID phase, the peak. He was not able to go out. He controlled his blood sugar. That he used to send me WhatsApp messages. Blood sugar fasting is now 80, 85, like that. And that with that level of blood sugar, this is what he did to his eye. And this is a one-eyed patient. A little bit of increase occurred in the cyst in 2021, and we gave him one injection. There was a little improvement in the cyst. But then what happens? From June to September, suddenly he comes back with worsening. So I asked him, what happened? You were controlling your blood sugar very well. And he says, look, I went back to my hometown. There was total loss of control. Hyperglycemia was uncontrolled during that period, and the worsening started happening. So basically, just 3 months of loss of glycemic control precipitated a worsening that had improved. You know, what the level we got from control of hyperglycemia, we had not got through repeated injections of anti-VEGFs. And I think this was mentioned in one of the previous talks. And this is what the objective of this presentation was, to highlight, A, there could be non-responding patients. These patients could show you that response to Ozodex, but the response to Ozodex also can decrease over time. So it's not that it will be continuously there. And with Ozodex, the possibility of a rebound is very high, which you need to cover with anti-VEGF agents. Aflibercept can work in many of these situations, but I think the lesson was for me, the maximum efficacy was of even moderate term hyperglycemia control. And that is the essence of this talk, that what we need to concentrate most is on the systemic factors. If we do that, a lot of our problems should probably settle. Thank you very much.
Thank you very much, Dr. Danish. This is also an excellent case presentation. You highlight about a certain topic that I think it should be A, not B or C for us when we are dealing with diabetic macular edema. So if there is any question from Dr. Fahad, Dr. Barqi, Dr. Raif. Fahad?
Hi, Dinesh. Excellent talk. I've definitely seen those kind of cases where you've improved their glycemic control and there's complete resolution or very impressive resolution of their macular edema and retinopathy. However, I'm never brave enough so although I insist and refer the patient for that improvement systemic control, I still think there's a proportion of patients where that won't be enough and their disease is significant enough that I would want to introduce laser, introduce anti-VEGF. But I agree that again, that it's not just dealing with the ocular factors, dealing with systemic factors, because what we forget is when they improve their sugar control, that's the most powerful thing that they can do to limit the progression of their retinopathy and reduce their risk of sight loss in the long term. And the thing that I'm always worried about is diabetic macular ischemia, because at the moment we have great treatments for proliferation, we have great treatments for retinal exudation, we do not have good treatments for macular ischemia. And if patients do not address their systemic control, they are still at high risk of sight loss due to that complication.
The patient this patient didn't reflect my bravery. He actually reflected the effect of COVID.
Right.
Dr. Barqi?
Yeah. Thank you, Dr. Dan. It's a very nice case, and also highlight the same scenario that Dr. Raif was mentioning about the BDR. And as you mentioned, we've seen in your case, despite the PRP was full, still there is an NVEs there, because personally, I don't believe there is something called complete PRP, as I believe also there is nothing called complete vitrectomy, because the only way to do a complete PRP is you have to do endolaser with indentation to make all the retina. So despite the fact what we've seen, that telling ourselves it's a complete PRP, it's not complete yet, and that's why we still see new vessels leaking despite all between the scars. So you ask yourself, from where this coming? Another point is the concentration of VEGF. If we have VEGF normal in our eyes, we all know that. So the problem came from overexpression of this VEGF. So you can imagine if you have overexpression, double or triple, it causes macular edema. So to reach the stage that causes BDR, we should expect a huge concentration of VEGF. And this give us idea about this might need more treatments, more injection. Don't give up early. After 5 or 6 injection, if the edema is not increasing, you're still on the right track, because you just need more time to block the overexpressed. Adding on top of this, the uncontrolled hyperglycemic control, it give us more. So you block some VEGF and second day another VEGF coming. So it's like a vicious cycle. So we need to be patient. We need to do, as you mentioned, PRP as much as we can, keep injecting, switching as you do. And all of this because of the higher concentration of VEGF together with the uncontrolled glycemic state. So thank you for highlighting this. Yeah.
Thank you, Ahmed. Dr. Raif, if you have any different comment or any questions.
Thank you very much, Dr. Dinesh, for this very nice presentation and a very important message that you reiterated for the glycemic control. I do have 1 or 2 suggestions or question. Why don't we treat the rebound of Ozodex with another Ozodex injection, or better to give a long-acting Iluvien injection, since it's not a steroid responder and there's no contraindication for re-injecting steroids?
Yeah, I think your own case is an example for that. See, if you give Ozodex with no break in the middle, the chance of increasing the intraocular pressure will go up. Actually, if you look at the studies on Ozodex, all of them will show you peak of the pressure coming at around 2 months.
Yeah.
It starts going down after that. By 4 months, it's back to the baseline. And then the next injection was given at 6 months. Again, 2 months later, the pressure was high. So if you give the next injection at month 3, you're not going to be able to let the pressure go back to the baseline. And actually, I would be against giving long-acting steroids for the same reason, because you don't give a period of washout. That is why in the FAME study, the incidence of glaucoma is much, much higher than with Ozodex, what you see with Ozodex. So I would rather...
that only applies to the steroid responders.
True,
but if he's not a steroid responder, then there's no point of, be extra cautious.
You see, the problem is, if you look at it, with Ozodex, the steroid response occurs in 15% of patients. But with triamcinolone, it can go up to 30%. Why?
30.
It's also dose dependent and also duration dependent. If you give too much steroid for too long, the number of patients who will become steroid responders or who will sort of respond in a positive way to the steroids will be more. So I want to keep steroid as my second line drug, not as my first line drug. I use it to break through the defenses of the eye, of the disease process. If I'm not getting a response to anti-VEGF, I give a steroid, use Ozodex. For 3 months, I have good control, then shift back to a more powerful anti-VEGF like aflibercept and keep the person under control. That way, and then if I have to give another steroid, I give it after another 3 months. So at every 6 months, I will give a steroid, and the rest of the period I will cover with anti-VEGF. It ensures the pressure will never go up. In virtually any patient.
Dr. Fahad, if you have comment about that, because I know you are having a different opinion. Okay.
Yeah, so Dinesh, I definitely share your thought that steroids is second line. Certainly, it's in my care. But if I have a patient with an insufficient response to anti-VEGF, then I often give the Ozodex. Make sure there's a good anatomical response. Make sure there's no significant IOP response. And if there isn't a significant IOP response, then at about 3 to 4 months, I might then give it a longer acting Iluvian to try and maintain resolution and reduce that patient's treatment burden. Yes, there are side effects with steroid, and I agree with you. However, in the real world, I find that the prevalence of glaucoma procedures is maybe 2 to 3%, not 5 or 6% as mentioned in the studies. But just to consolidate Dr. Raif's point, if you have a patient who've given a steroid challenge to, like Ozodex, and there's been no response, then the risk of a steroid response with Iluvian is significantly low, and actually that improves your safety profile. If I had a patient where the vision was not improving on anti-VEGF, but improved with Ozodex with a pressure response, I would still consider an Iluvian to improve that patient's vision. I would have that honest discussion about the patient. Look, if we can't control your pressure, are you prepared to have surgery? And you often find most patients would rather have a longer acting drug with the freedom of injections, and they will accept the risk, even if it's 1 in 20, 1 in 30 of a glaucoma procedure. And if you ask our glaucoma colleagues, they aren't afraid, they're not afraid. They're not averse to us doing this to patients. They're happy to rescue us. And often you find those trabeculectomies will often be more successful because there's steroid on board. So it has an anti-fibrotic effect and improves the filtering ability of that bleb. I'm not saying that we should be using steroid willy-nilly. It is, in my practice, is second line, but in the right patient, it has really made a big difference to their vision, but also to their treatment burden.
Thank you very much, Fahad.
I think that's worth considering. This patient, incidentally, was one-eyed. So
I agree.
We are talking about in general. Okay.
I'm talking about in general. That's a good point, Dinesh.
Yeah. I have small comment about the using or the management in case, for example, steroid, especially Ozodex. In Ozodex, I mean, the effect is not going up to 6 months now. What we are feeling, they are finished within 4 months. This is very important. So I think if we are thinking in the way of Dr. Danish thinking, so we have to repeat the Ozodex 3 times per year if the patient needed. But sometimes, I mean, if there is an increase of intraocular pressure and you can't control, then you can even repeat after even the 4 month is finished, then you can give another steroid, which is Ozodex, or as Dr. Fahad mentioned, we can go for the Illuvian. And also I want to mention that there is the percentage of having a surgical intervention after I'm saying about Illuvian, especially in real life, it's completely different than what it was in the film. It is less, even not 2 or 3 as mentioned Fahad, even less than that. It is 1% in the real life now. We didn't find, we are having so many cases and we didn't find even sometimes even we are controlling the intraocular pressure with 1 drugs, if there is. There is something also to add. We are having increase in intraocular pressure with Ozodex, but when you are using Illuvian, you are not finding, I have some patients like this. So this is just to have, diabetic macular edema is really sometimes frustrating, like what you are mentioning. And there is one point I want to comment. There is a difference between the central, thickness, and you cannot match it with the improvement in the visual acuity. Even in the case of Dr. Ra, if you can see, there is an increase in the fluid, but the vision, it's improving, I don't know. This one, it's happened several times with us. And sometimes you are having one cyst, it's a parafoveal, and you cannot do anything, but the vision is there and you cannot do anything. So you can sometimes watch, I don't know, but we are thinking sometimes of ischemic changes. So as Ahmed Al-Barqi mentioned, we are still, we need something that's maybe better to understand about the difference in dealing with diabetic macular edema. And the last point, which Dr. Danish mentioned, or the message that Dr. Danish tell us about the controlling of systemic causes, especially the blood sugar. I don't know if it is any from the start, if we have certain patient with central involvement with a good visual acuity, there is so many patients I have seen and we didn't do anything, we just asked and they are improving. But after starting with, the patient you control and there is no improvement, you already start. I don't know if there is a validity to stop and then you can say it is going to be controlled by controlling the blood sugar. This is, I don't know, we need to figure out. I want to hear, yes, Dr.
I don't think we would do that. I don't think we would say that we will stop the drugs, the intravitreal treatment and use only hyperglycemia control. That would not be the way to go. But I believe that in many of these studies, what you get at 3 years is partly a result of the patient becoming more aware in controlling his blood sugar. While we claim the effect is coming from anti-VEGF, part of that effect is coming from the fact that any patient who's getting 8 injections in a year is going to be very careful about his blood sugar.
I think we can go now to Dr. Fahad, his case, then we can continue. You have Dr. Fahad.
I don't have a case.
Okay, so we can continue discussing. Okay. So if we get now, we want to get now like a certain point to highlight it about our way of management of dealing with diabetic macular edema. Sometimes you feel there is a central involvement and you are injecting and the patient, the fluid increase as you see in the, OCT, but the visual acuity improvement. What is now what to do? To continue injecting or just to follow, to use treat and extend, or you do BRN? So I need
if the vision is not 6/6,
yeah,
you can still inject.
But if there is no improvement,
even if there's no improvement, but you've got no improvement in OCT, but you've got an improvement in vision.
But already stop. I mean, sometimes you reach, for example, the patient reached 0.6, 0.7. It is not 6.6, and there is no decrease. The cyst is there. Whatever you are doing, you are giving, and then there is no improvement.
I think then you stop. If I have after 2 injections and 3 consecutive OCTs, I have an identical picture on my OCT and have no change in vision, I will not treat anymore. I will, but I will follow up every 4 weeks. And if there is a deterioration, I will consider treatment. Otherwise, I will just follow him up.
What type? Let me ask Dr. Ahmed Al-Baqi, the same case or same scenario as Dr. Danish mentioned, how you will treat with this patient? You will do PRN or you will start again 3 loading dose? Or
okay, usually as we agreed that we should treat as much as we can, and if we reach a stage that there is some small cyst there and here and it's not clear or drying up, you can stop at that point. So, but if you have an naive patient that you are giving it anti-VEGF and it's not improving, personally what I'm doing, I switch directly to steroid. I don't believe in switching among anti-VEGF and DME for 2 reasons. The first reason, I personally tried that, I didn't find the result, and also there is no evidence based for that. So I usually switch, and I switch early, honestly. I mean early if after 3 monthly injection, I didn't find a proper response. When I mean proper response, I mean at least 20% improvement in the thickness and the macular thickness, or more than 10 liters improving. So if there is no improvement on that, I switch early to steroid. And there is a publication about that, to switch or to continue, and they found that if you only switch after 3 months in addiction to Ozodex or steroid, the results are there much more important. But coming back to your question, if I do all these tools and the blood sugar is controlled, so what to do else? So you have to watch and see. But if you start to stop again, you have to watch this patient very closely, because the process is going there, and this small cyst at any time it might increase. So you should keep an eye on those patients. But fortunately, actually, the percentage of those patients actually in our clinic is not high, to be honest. Most of the patients, especially if they came early, they respond well. Those patients are not too much seeing our clinic.
But we are still facing this.
Yeah,
Ahmed.
sure.
Okay,
Yeah,
yes, Fahad, yes.
Mohammed, no, I want to support Ahmed's approach. So I think if you've given 3 to 4 monthly injections and there's less than a 20% reduction, and I like what he said, at least a 10-letter gain. So he's setting a high bar there that he would consider steroid. There's an interesting paper that was published, I don't know if it's ophthalmology retina or in retina, where they looked at the cytokine profile of eyes and matched that with how well they responded to anti-VEGF. And what you found is eyes with the super responders to anti-VEGF had a very had a lot of VEGF in their cytokine profile. Those patients who didn't respond as well, yes, had VEGF, but there was an increase in the expression of inflammatory mediators within the cytokine profile. And this is, we always knew that, and we inferred that from the data. But this is one of the better basic science proofs that an eye that doesn't respond very well to anti-VEGF is because it's an inflammatory diabetic macular edema, and therefore you need to treat that inflammation. And at the moment, steroid is our best weapon for that. Yes, there are issues that you need to manage with steroids, but I think it's the thing that matters most to the patient is the gain in vision. And I've never seen a patient worry about taking a drop when their vision is improving. So I wasn't hesitate about switching to steroid in that group of patients.
Okay, Dr. Danish or Raif?
No, I agree. Actually, that point I should have completed. If the end point for saying no more treatment or no more intensification is steroid. If I have after given steroid, the anti-VEGF, and got no response to these 3 OCTs, the next thing is one dose of Ozodex. Then what I get through Ozodex, I consider as is the level 2. It doesn't improve beyond that. It's not that after Ozodex, 3 months later, you give another anti-VEGF, it'll improve. Or even 1 month later, you give another anti-VEGF, it'll improve. That is more or less the maximum improvement you're going to get. And that I accept as my baseline, that this is what I will get.
Dr. Raif?
I will assume that the question about your case is that it received steroid and it was not responsive with regards to the macular edema, and then again it received anti-VEGF and it stayed the same without the reduction in the central subfield thickness or intraretinal fluid collection, and the same visual acuity. So in that case, I would suggest to go for a sub-threshold or micropulse laser. There's a growing trend and there's a growing interest in the effect of micropulse laser in reducing the treatment burden of anti-VEGF injections in diabetic macular edemas, and as well as to reduce the resistance to anti-VEGF or suboptimal response. So maybe that's an answer to your question for this patient.
I have a question regarding would that micropulse laser cause an improvement in macular edema without an improvement of vision, or does it actually cause an improvement in vision? Because I somehow get the feeling that the vision doesn't improve, the edema may go away.
The evidence is there for improving the macular edema, for the reducing the intraretinal fluid collection.
Yes.
But without, you mean, as a question, Dr. Danish, you want to get the answer, without improvement in the visual acuity, right, Dr. Raif?
Some people do improve, and some people do improve, and some people do not. So you cannot tell which patient will have the preferred response, let's say. But there definitely will be some improvement in the macular. The same applies to the vitrectomy. So if you go for a vitrectomy for diabetic macular edema as a final last, let's say, third weapon resort for diabetic macular edema, you will have much decrease in the retina thickness. But would that be reflected in visual acuity? There's no evidence that supports.
It's not. Usually it is not. That is the whole problem.
And
yes,
sometimes you need also after vitrectomy to give again steroid, maybe to treat, maybe there will be an increase in the diabetic macular edema, and you need to go also back to the steroid for the treatment of even after vitrectomy.
Yes.
Sometimes, yes.
I have a comment, Dr. Muhammad, if you still have time, or we are done?
Yeah, because already
just a comment about the visual acuity, because in our practice and all the study, we count on the best corrective visual acuity. And sometimes, I've seen, I don't know if our colleagues seen this, the patient came to you in the clinic and they asked him, how do you feel today? He said, yes, I can see better, but on the chart, it's the same. So
quality-wise.
Sorry?
Quality, because sometimes
so we are
the
not
quality of the visual acuity.
If you do for those patients any macular function test like macrobarometry before and after, you will surprisingly find the function improve, but the on the chart it is still the same, but the quality of the vision improves. So we shouldn't ignore that, because at the end of the day, all our job is to give a better vision, either in quality or quantity. So in most of the study and most of our life, because we don't have time to do macular function for every patient, for sure it's not practical. But again, so if the fluid is there and the visual does not improve, I think those patients might have a better quality rather than quantity. But patient is, so you can ask the patient verbally, if you ever feel better, you can see clearly, or in reading or something like that. So it also should be considered in this way.
Okay, Ahmed, I think you raise a very important point. We are having so many patients about the quality of the vision sometimes, but this one, I can say we found it mainly in AMD more than in diabetic macular edema.
Sure. Yes.
But still we can face. I have one who is having 0.9. He can see visual, in the chart 0.9, but he is not happy. He is not happy. He can say he's making a drawing and something like that, painting, and I feel the things is tilted, I cannot see properly, wavy. So what I can, sometimes it's very important also is and in the other hand, he is seeing in the other eye less, which is 0.7, but he is very happy more than 0.9. because the type or the clarity of the visual acuity or the quality is more important. He can see in the quality rather than quantity. This is also another problem we are seeing with the patient. I don't know if there is any point anyone want to highlight. Maybe I just want to ask you, Ahmed. I will ask you before I forget this point.
No, it's okay.
Sometimes, Ahmed, you mentioned you are talking about the fluid. I think the fluid. Sometimes there is no. I think we raised this one. There is no matching between visual acuity and fluid. Okay, especially if the fluid is parafoveal. I want to know. I mean you to highlight the central. What do you mean by the central involvement? You are talking about fovea or the macula itself, or around? Because I think Dr. Raif, when he gave his example, the effect was parafoveal. I mean, the central was okay. So the improvement of the vision, where it come, while the vision in the center is not involved.
Yeah. I mean, yes, the mean, when you say central, this means central subfoveal fluid. This is the most important one. So this is the most affecting the vision. If it is parafoveal, definitely the vision will not drop compared to the subfoveal. And but you still the same. If it is parafoveal, you still to treat it because it's now parafoveal. But if you don't treat, this fluid might migrate and increasing in the size and the cyst or the number.
Before migrate, Ahmed, before migrate, it will going to affect vision or not?
It will affect the vision, definitely.
Okay.
Yes, it will affect the vision.
But how? Why? It's. I mean, when we are having, what I want to highlight certain point for our colleagues that are listening to us. The central, the effect, it is more than if you are having a parafoveal, right?
Sure. Yes.
Okay. If you are having a diffuse macular edema, then you are. Is there any chance to start? I mean, with steroid as a first line of treatment? This is a question for everyone. I mean, we want to highlight a point about when to use the
steroid as a first line.
First line, yes.
Okay. First of all, the first line.
I need Ahmed a very sharp point so we can go to the other colleagues.
Very recent history of stroke or any event, cerebrovascular event. Second thing is pregnant. I don't use anti-VEGF. Third one, victimatized eye. I don't start with anti-VEGF. As a starter with the steroid. Pseudophakic with diffuse or a lot of hyperreflective dots, diffuse subretinal fluid. Pseudophakic, I might consider Ozodex or steroids as a first line, but the first three is the top priority.
Okay, Dr. Danish.
Yeah, except for the systemic reasons, I will not use steroids first. I'll always give a chance of anti-VEGF. If in my first three anti-VEGFs I don't get adequate response, I will shift to steroids.
Okay, to continue, Dr. Danish, when you will shift? If you, for example, after 3 or 6?
3. I won't wait for 6.
Okay, Dr. Fahad, you are me and you, Fahad, we are different a little bit, I know. So that's why I will listen to you at the end.
No. Actually, with regards to where I would use it first line. So in the UK, we can only really use steroid in a second line fashion, just because of the way our guidance and our funding is devised. But essentially, but like Ahmed has said, if I had a pregnant lady, I would make a request to the health authority to give her Ozodex. If there are systemic reasons, then yeah, I would want to avoid anti-VEGF and give a steroid, and so that's where I'd be first line. But then, like Dinesh, though, still anti-VEGF is my first line, except for those couple of exceptions.
Okay, there is something. I mean, just if we can make the scenario like this, we know that the DME, let's assume, no, not to assume, we are knowing now the pathophysiology of DME not only there is an inflammatory process, right? And so many times, yes, you get a response to anti-VEGF, but if you give a steroid, you will feel that you are, tackle the two things at the same times, and you get the improvement. Why we need to wait? If the patient is pseudophakic, and we can get the improvement, and we are tackling the inflammatory and decrease the edema, and we can continue after that, with anti-VEGF or steroid again.
more than a century ago, a medical philosopher said, do no harm. And that's basically the reason why I will start with the safest drug first, even if it is less effective. And I mean, I got this thought when I once had to make a presentation on safety versus efficacy, safety and efficacy. So, and I was just thinking, what do I want more, safety or efficacy? And then I put myself a question. The most efficacious treatment for ARMD, even today, is subfoveal argon laser. Destroy the lesion completely, 100% success, no recurrence. Would you do it? No, because 100% loss of vision. So the basic thing is we are not looking for efficacy as the first line. We're looking for safety as the first line. And the efficacy comes next to that. So we have to draw that balance, and that balance comes with anti-VEGF as the first line. And when it doesn't work, shift to steroid.
Fahad, last comment.
No, so just like Dinesh said, I am somebody who uses steroid a lot. I'm a great believer in steroid, but there is unfortunately still a number needed to harm with steroid that isn't there with anti-VEGF. And that is why I will use anti-VEGF still as my first line, and I will use steroid as my second line for that insufficient response. And it's because there are some eyes that respond, even though there's an inflammatory pathway, that respond beautifully to anti-VEGF, and then you minimize that harm to the patient. And like with all medical decisions, it's a risk benefit. But I'm not so blinkered that I will not use a second class of drug. I will still consider the steroid, but still, at the end of the day, we do no harm, and there is a number needed to harm with steroid, even though it's safe and the risk is low. It's not as safe as anti-VEGF.
Also, one more point, Dr. Muhammad, if you, yes, I remember just to highlight also when to use the steroid also. Personally, also, if I have a case with the hard exudates threatening the macula or about it, I think steroid has a rule, and there was seen in Bivordex trial. And personally, I've seen that. So if you have a case with the hard exudate threatening the fovea, I use it very early because I want to clear it before, because if you have a plaque under the fovea, the vision will not improve at all. So in hard exudate, you should think earlier about steroid also.
Ahmed, but also, if you don't mind, also anti-VEGF, they can also manage the hard.
Yeah, but the clearance is
if
more
you continue
with the
if you continue with, for example, 5, 6, 7, sometimes injection, you will feel that also there is an effect of.
Yeah, but the clearance is much more faster with the steroids because these.
Raif, I'm forgetting you because I cannot see your photo. That's why I cannot see you. So Raif, there is I cannot see him. He is not showing. Only his
Dr.
name.
Raif. Yeah, Dr. Raif.
Okay, Dr. Raif, not
I'm
you,
really
Ahmed.
sorry about the camera.
I don't mean that to forget. Yeah.
I really agree with all my colleagues about the indication of Ozodex, and I would like to add the indication of vitrectomized eyes. Where Ozodex would provide the most long durable modality of treatment for the treatment of diabetic macular edema, and as well for the last note that Dr. Ahmed Barki mentioned about the hard exudates. But also we can combine Ozodex with anti-VEGF, because this is a real permanent sight-threatening problem that if it reaches under the fovea, then nothing would make any effect.
What do you mean by what do you mean by, do you combine at the same time, or as
at
Dr.
the same
Danish?
time while the Ozodex is there, we can inject anti-VEGF.
When?
If it's really so, let's say after 1 month.
After you give the steroid, after 1 month. Okay. So is there any comment on Dr. Raif, or otherwise we can have a last comment about where we are now? Do we think we are having a very good baseline of management of DME, or we are still looking for or wondering or asking for something different to have to treat the diabetic macular edema? Dr. Danish, start with you.
So you see, the pathogenesis starts with hyperglycemia. That's the first level to manage. The hyperglycemia goes through 4 different pathways, including the polyol pathway and the hexosamine pathway, the protein kinase, C kinase pathway. Now, these 4 independent pathways cause one action through the VEGF, but there are also other levels at which we can act. And if we act at 2 levels simultaneously, which is what the newer drugs are trying, we may get a better effect. And we've seen that if you use only anti-VEGF agents, there's a point beyond which you don't get resolution. And there are some patients in whom you don't get a resolution. There are only 25% of patients who are very well managed by anti-VEGF alone. The rest require something in addition. And I think that's where we still have need for other drugs. And I hope that maybe in the next few years, we'll get them.
So do you think what is the percentage now we can reach up to what for management if you use all the weapon? 60?
We have, yeah, if you look at it, 25% you have who will respond very well, the elite responders. In another 25% to 30% are patients who will, in a slow fashion, respond over another 6 to 12 months of treatment. And then there are going to be 30% patients who actually don't respond. And those are the patients where we have no answers yet, and we are struggling.
Okay, Fahad?
I mean, for me, it's just an exciting time to be a retina specialist. I feel very lucky that I have these drugs available to me now. The Lucentis, Eylea, Ozodex, and Iluvian, and I've had some really good success with these drugs. However, I am looking forward to the new developments, viral vectors, PDS, faricimab, brolucizumab, because I feel that we will be able to manage these patients probably better with just VEGF, or looking at double antibodies, biallelic antibodies. And I do think, in the next 2 or 3 years, the role for steroid, I think, will be less, because we'll be able to manage DMO better with these more powerful anti-VEGF drugs, or we'll be able to give more sustained delivery of anti-VEGF into eyes. So I think the durability treatment will be better. And so for me, I'm kind of very excited. I think it's promising, but I think the drugs we have now have been a game changer and have stopped many thousands of patients with diabetic eye disease going blind. So, if you said to me, I can't have any more drugs, this is all you have, I'll be very happy. I'm managing very well, thank you.
Thank you, Fahad. Ahmed, if you have anything to add.
Yeah, I agree with my colleagues that we're still missing something still in the pathogenesis, because as we mentioned, all the cases that presented tried all kind of treatment, laser, anti-VEGF, 2 types of anti-VEGF and steroid, and still the edema there. So that's highlight the point that we're still missing something. We need to tackle another pathway, not only the extracellular pathway. And as I mentioned in my presentation, there's ongoing drugs in the pipeline. Even we have oral, we have subcutaneous drug coming, we have extended release device coming, everything is there. So I think we need to use, when this kind of drugs, the new drugs introduced, I think it make our job easy to tackle all aspects of the anti-VEGF. And also I want to highlight something else about we have in our clinic, as the cases we've seen different response pattern, because I think most of the cases, I'm not going to say all, it's not only VEGF only or inflammatory only, it's an overlap between many factors, including the systemic effects, not only diabetic, if the patient had nephropathy, if the patient cardiac issue, if have something like ischemic changes also there, if a mild ischemia. So in those cases, they have more than factors come together. It's not only purely VEGF. If it's purely VEGF, one injection will make it dry. So we should consider this while treating this patient. We should be patient and definitely control the systemic condition of the patient, not only diabetic, other diseases, and keep eye on this patient and treat early, switch early. And I hope this will help us at this stage, waiting for another drug to come in the market.
Raif?
So again, we're all waiting for the renovations in the pipeline from the major pharmaceutical companies. But I anticipate that in the near upcoming future, that there will be a bigger role for the micropulse laser. Now the ongoing studies I've been following, they're showing real interest in the micropulse laser, that it might at some point in time replace altogether the pharmaceutical treatment for the treatment of diabetic macular edema. And we'll see how the studies will show up.
Thank you very much. I think we came to the end of this session. I think still DME is a challenge, and we are waiting for a way to treat. But as Dr. Fahd, I like what Dr. Fahd said, that we are very happy and we thank God for what we are having, because what we don't do during the last, let's say, 15 years, the method of treatment of DME is completely changed, and we are completely different than what we have before. Only one weapon, which was the laser. Now we are having several weapons, and we can use in a proper way that we can manage, and we have to deal for each patient is different. This is the most important. Every patient is different than another one. There is no one you can say is respond to this one, maybe the other one. Even sometimes you will find one eye respond in one way, the other one respond in another way. So I think we can depend on our experience and from our learning, and we hope that we can get something in the future, as all our colleagues mentioned, so we can accelerate and gain more of the vision, maybe long time of period of time we're having, or slow releasing for a long period of time, and another way of management of diabetic macular edema. I want just to mention that for our colleagues, if the management, even they can post the link for the certificate of attendance. At the end, I would like to thank all our colleagues. Thanks, Dr. Danish, for your time. Sorry to keep you till this time. I know it's too late in India, but we are happy that you are with us, and thanks for being with us. Dr. Ahmed Al-Barqi, thank you, my dear friend. Dr. Fahd and Dr. Raif. I would like to thank all the attendees and participants. They are with us. Thanks for the sponsoring Company Novartis, and we hope to see you after a while, inshallah, maybe after 1 week or two in another sessions. Thank you.